Hello, good morning. Thank you so much, Indian Society of Thoracic Surgeons, for permitting me to attend this important meeting through a recorded session. Even though I wanted to be personally present, due to some pressing reasons, I could not be present. And I'm talking about the usual problem, the tuberculosis, for which thoracic surgeons have been engaged since at least two last centuries. Can I share my slides now? Okay. So, never-ending problem. All of us are talking about ending tuberculosis, and the government of India has declared its intention of ending TB by 2025. Nevertheless, we still feel that this target may not be achieved, as the progress towards achieving this target is a bit tardy and has been particularly hampered because of the COVID epidemic. About TB surgery, with which I have been engaged for the last 3 decades, it's a rather high cost interventions with moderate to high risk of complications, and it is indicated for patients who are likely to derive the maximum benefits. And it is contraindicated to patients who may respond to medical therapy alone. So one point is clear, that if a patient can be treated by medical management, there is no role of surgery in pulmonary tuberculosis. Now, when surgery should be performed, the decision should be taken in a combined manner by TB physician, surgeon, anesthesiologist, and other specialists when comorbidities are concerned, and in close consultation with the patient and family, because many of these patients may have comorbidities, and the result sometimes may involve a particular percentage of mortality and morbidity. Now, what is the role at present? Most important role which is talked about is drug-resistant tuberculosis. If we have very few number of drugs available to treat a patient, it's a contested intervention and a topic of debate also. But it has a great role in suitably selected cases. It improves outcomes of treatments. And of course, we use TB surgery in a number of cases for symptomatic improvement in the quality of life of the patient. So that all the indications can be divided to three main categories: diagnostic, and number two, active pulmonary tuberculosis, which may be MDR or even drug-sensitive TB if there is a large cavity or any other reason and the sputum is persistently positive. And a large percentage of patients have complications and sequelae after full treatment of tuberculosis, whether hemoptysis, destroyed lungs, empyema, mediastinal lymph node abscess, paravertebral abscess, osteomyelitic ribs, or tracheobronchial disorders. So what are the current indications of surgery? As per the consensus document of WHO, emergency, urgent or recurrent hemoptysis. This is an emergency indication. In emergency means profuse lung hemorrhage or tension or spontaneous pneumothorax, for which many of us have put an intercostal chest tube drainage. And urgent indication, irreversible TB progression. I think this is something which has to be understood, that those patients who have a lesion in lungs, and we know that despite treatment, the lesion is progressing. At that stage, if surgeon can resect the involved segment and add appropriate chemotherapy, probably that is the patient who can be prevented from developing into bilateral extensive disease, which will eventually kill the patient. Or recurrent hemoptysis that cannot be stopped by any other treatment. So in this consensus document, the WHO mentioned that localized forms of cavitary TB with continuous Mycobacterium tuberculosis excretion, which is confirmed by bacteriological examination after 4 to 6 months of supervised anti-TB therapy according to the drug sensitivity testing. So appropriate treatment has to be put in, and then the patient is put on appropriate drugs, and yet the patient is not converting. An MDR or XDR TB, which is characterized by failure of anti-tubercular therapy. And secondly, there are many complications and sequelae of the TB process, which may be because of drug-sensitive TB or drug-resistant TB. Spontaneous pneumothorax or pneumothorax, pleural empyema with or without bronchopleural fistula, aspergilloma, nodular bronchial fistula, or broncolith. Then complications and sequelae of the TB process, which involves pachypleuritis or pericarditis and post-TB stenosis. So what is this situation now? I think I mentioned that if a culture is positive beyond 4 to 6 months of appropriate and supervised chemotherapy, patient should be considered for surgery. And if culture reverts to positive during treatment, and all patients with XDR TB, they have to be considered for surgery. Other indications we can skip off now. If I talk about our experience, total in the last 15 to 20 years, we have 20 years, we have done 173 cases for drug-resistant or persistently sputum-positive state, out of which males were 119, females 154. Pneumonectomy was done in 94 cases, lobectomy in 44 cases, bilobectomy in 21 cases, and thoracoplasty in 17 cases. Sputum negativity was achieved in 126 cases. There was early mortality in 4 cases and late mortality in 8 cases. There was late recurrence of sputum positivity in 12 cases, and there many cases were lost to follow, as is usual in India. So, but overall, we see that we have achieved persistent sputum negativity in a number of cases, which is significant. And surgery for hemoptysis in a post-TB sequelae, I think most of us surgeons continue to deal with this situation more often than the earlier indication. When there are chest symptoms which are persisting and causing 3 or more bouts of pneumonia in a year, or there is hemoptysis more than 500 cc per day on more than two occasions, or mild to moderate hemoptysis which is persisting in spite of medical treatment, and sometimes emergency life-threatening massive hemoptysis. Many of these patients nowadays are actually attempt is made to treat them by bronchial artery embolization in the beginning and taken up for surgery when the setting is more elective. So in this situation, what has been our experience? This has been the largest number that we have dealt with in the last 20 years. Total cases were roughly 1900, and common indication of hemoptysis was the commonest in 1400 cases. Recurrent chest infections 240. I think out of these 643 cases are tubercular cavities, and aspergilloma was seen as 250 cases, and post-TB bronchiectasis 616. So surgeries performed in this group, less surgeries on pneumonectomy, more were lobectomies, roughly double of each other. Bilobectomy was also done in 105 cases. Occasionally, we got away with segmental and wedge resection in 37 cases, and thoracoplasty in 101 cases. Approach was mostly open cases, or 9 cases in recent years. We have been attempting to expand or broaden the horizons of cases being taken up by video-assisted thoracoscopic approach, which is usual all over India, but we have been successfully performed this operation only in 9 cases so far. Results: there was mortality of 2.2%, 42 cases died. There was control of hemoptysis in majority of cases. Minor rebleeds occurred in 39 cases. Massive or recurrent troublesome bleed in 12 cases, which were managed by completion pneumonectomy. So overall, this is the group which gives the most gratifying results. Empyema, we have treated 10,000 plus cases at NITRE, and detailed data is very difficult to collate, but it was treated by various methods, including needle aspiration, tube thoracostomy, window thoracostomy, decortication, thoracoplasty, or lung resection, depending upon the stage, extent, and presentation of the disease. These are some of the cases of MDR-TB that we have operated. One can see cavities which require a resection, localized resection. See, this is a cavitary MDR-TB. This is one cavitary MDR-TB which presented with active profuse hemoptysis, and I was taken up for emergency surgery. And this is an operative photograph showing the control of various blood vessels, which is a hallmark of all lung resections. These are our operated cases of lobectomies. Post-operatively, the lung expands and takes up the entire space, and one can see the lung is almost as normal as if no surgery was done. This is a typical case of XDR-TB, which was taken up for surgery, and a pneumonectomy was performed. This is post-pneumonectomy X-ray. Then this is a pneumonectomy procedure, which is just a representation of the operative procedure. And very often we use staplers at least for the control of bronchus, but even for vascular control, sometimes we divide them with staplers which are available nowadays. These are other cases of pneumonectomy. This one slide I always am very keen to show. This is an operative photograph of thoracoplasty and epicolysis. The apex of the lung is fully mobilized and brought and stitched to the third intercostal space, so the cavity completely collapses. These are our post-operative X-ray films of cases in which thoracoplasty was done. And this is a VATS lobectomy which we recently conducted. Some procedures in which the disease is not very old and adhesions are not massive, I think they can be taken up by video-assisted thoracoscopic approach. I had also done a mission in Armenia in 23, in which 5 cases of drug-resistant TB and 1 case of intractable chest was sinus were operated. 1 pneumonectomy, 4 lobectomies, and 1 thoracoplasty was done. No mortality was there, and sputum negative status and control of symptoms was achieved in all cases. I think I have mentioned this, that this is surgery. Many times people ask that should a sputum positive case be taken up for surgery? Yes, patients can be taken up, but the operating theater personnel have to be protected by HEPA filters and disposable anesthesia circuits, and the operation theater should have a continuous exchange of air filters. I think I'll skip these slides for the time, but this point I wish to emphasize that recent technologies that have improved the results of TB surgery include a double lumen endotracheal tube put in by an expert anesthetist with the use of a pediatric fiber optic bronchoscope. Surgical staplers have made our results much better than before. Tissue patch, fibrin glue, etc. for troublesome bleeding, argon beam coagulation, and digital portable chest drainage system, which is very useful for making the lung expand completely after surgery and preventing residual space problems. Some of the contraindications for surgery should also be understood. Extensive cavity on both lungs or impaired lung function tests and body mass index being very low. Such cases should not be taken over surgery. And one important indication is active bronchial TB. This patient should never be taken up for surgery. Post-operative care is standard as in any other thoracic surgery. There is a published literature. I think these are some important published literature which is showing what are the results after surgery. And these are some of the YouTube videos which have been made in our department, in which practically all the procedures which are done for TB surgery have been demonstrated. So in conclusion, surgery for TB is a multidisciplinary and challenging proposition, and it has to be done in selected cases of drug-resistant TB, in addition to reserved drugs which have been selected after correct laboratory testing. This offers the best chance of prolonged sputum negative state or cure, and surgical intervention should be offered and made available for greater number of cases. Thank you, sir.